Uh, can you guys hear me? I don't know what's up with my.
Yes, we can hear you.
I don't know what's up with this background, and I don't know why I don't.
Is your camera lens
It's
open, Faye?
It's
Sometimes,
on.
yeah.
The camera says it's on, but
Is that Dune?
I know, right? Yeah.
I have no idea. I
That's
promise
funny.
that I didn't ask for it. Oh my goodness. Let me just see if I can go out and back in and actually show up because I can't look at that the whole meeting. Hang on.
Kristen, have others accepted that aren't here yet, or does it look like we have everyone?
Let me check. Everyone who accepted the meeting invite is here.
Faye's getting back in.
I'm so excited to see what happens. I'm like on the edge of my
I know.
seat.
Yeah, right. There we go.
All
Oh, there
right,
she
I'm
is.
here.
Yeah.
Oh my God, that was too funny. I'm back.
There she is.
Yep, I'm here. That was very funny, and I don't know how it happened, but there are a lot of mysteries in computer world for me.
Well, great. I think we're all here. Just going to the agenda, and does everyone have the agenda? Did anyone not get it? I just want to make sure everyone has it in front of them before we start. Great. So for background too, Faye had reached out a few weeks ago, requesting a meeting to talk specifically about the two primary care bills that are in the legislature right now. And specifically the impact or the relationship to the GMCB work. So that is what we're going to do tonight. So the agenda says roll call. Kristen, is that something we have to do, or how do we generally do that?
I can do it on my end without having to
Sure.
disrupt the meeting.
Yeah, that would be great. Thank you. And then the next thing is just a brief update from the Green Mountain Care Board. So Elaine, I'm not sure if there was anything you specifically had in mind to update this group on, or just a general update.
I don't have any updates. I have kind of background, couple bullets I was going to remind folks. I mean, I think this group is up to speed on a lot of it, but just a reminder on kind of the challenges we have in primary care and some of the things that are evolving. I know, there's a lot going on with the Rural Health Transformation Fund and unwinding of the ACO and Blueprint. So thinking about how funding is changing. But is that where you wanted me to go, Emily? Or
Sure. Yeah.
So we have around, 28 million in population health management that was previously through the ACO. There was about 10 million for Blueprint and SASH, 14 million in the population health base and bonus payments to providers, 3.4 in other PHM programs. We have the CPR program for independent primary care. So a lot of these funding streams you are all aware of are kind of being rediscussed and re-envisioned as we move forward with either the AHEAD model if that's an option, and then I know Jill has been speaking with groups around some of the money that could be available through the Rural Health Transformation Fund as a stopgap, but that this bill, and we'll walk through a little bit of kind of what these two bills, I guess there's one in the House and one in the Senate, that kind of do similar work, would be one means of kind of supplanting what we previously had. So we're really curious about your thoughts about the bill, and then our role specifically, as it's outlined here. I think everyone, hopefully you've read both bills and are coming here to give us some advice, but I think they're largely administered by the Agency of Human Services, a smaller role for Green Mountain Care Board and DFR. So we have some more tailored questions about some of those intersections. I think Kristen sent out a document with links on the AHEAD model. I think there's still, while there is an enhanced Medicare payment through that model, there's still a lot of other things that we're learning, and how that payment might work and different options for that reform is still to be determined. So, what you have seen online in kind of public forums is really as much information as we have, and we're still learning about, model terms and specifications. So I don't have any more information to share, but I wanted that to be clear. And then, I think just reminding folks that, the legislature passed Act 68 last year, which directed the Green Mountain Care Board to use its provider rate setting authority to establish hospital reference-based prices. This could include primary care. And then I think even outside of that, it said the board may establish floors for primary care providers. So I think some of our questions later will get to kind of how some of the board authorities might intersect with some of the aspects of this bill. But the first series of questions we have, and Emily, do you want to jump into the questions?
Sure.
Or,
Yeah, we might as well. Yep.
yeah.
And just sorry to Elena, just wanting everyone also to know that the links to the bill are in the agenda if you haven't looked those up. So that's where you can quickly access them if you'd like to refer to those while and during our discussion. So
Yep. And I'm happy to pull up any language. I've got them ready to go if we want to go to any sections. But I think at a high level, the bills aim to kind of create, it's called primary care payment reform, but it's basically building a mechanism to finance primary care. I think there are a lot of questions that have been, I know folks are talking about, attribution. We were in the was it the statewide strategic plan, or I'm getting all my committees mixed up, or the comprehensive primary care group, talking about, other elements of payment methodology that we would need to think through to make this work. So I don't want to duplicate that work, but I think what we would like to understand, I think the first question we have is what are the biggest implementation barriers that could prevent these bills from serving their intended purpose, which would be to expand access to primary care and ensure it's adequately funded. So I'll just start there with the big one.
Alina, or I'm not sure who to ask, maybe Kristen. Forgive me, I've had kind of a bonkers day today, but did the comparison go out of the two bills where it's kind of side by side? There's something that by state put together. I found it helpful to look at that. I don't know whether that got sent out to the group or not.
I don't believe it did, but I'll find it and send it out.
So that's just a document that by state put together that puts the House and the Senate bills side by side. It was helpful to me to sort of see what the commonalities were, which is actually a great deal of it. And then the other thing that I have learned in the last month or two, as I'm chairing the Primary Care Steering Committee, is that there's kind of a similar bill in the Massachusetts House that has some traction. And to me, it was just helpful to know that this was not, we didn't make this up out of thin air, this idea of having a primary care fund, basically to do per member per month or capitated payments to practices for primary care. It's an idea that's already sort of underway other places, and it was interesting to read about their bill. And if anyone wants to know more about that, I have some summaries of that I've been given.
If you're willing to send those out, that would be great.
Yeah, of course. Yep. Do you want me to send them to Kristen and have her disperse it to everyone?
Okay, I just sent that out,
The side-by-side summary?
the comparison.
Yeah, and I think, David, you were talking about when I mentioned I could send out the stuff about the Massachusetts bill, is that right?
Yeah,
Okay,
yeah.
yeah, I have some stuff on that I think I can send. And should that go to Kristen too, to be dispersed to you guys?
If you wanted to just reply all to the emails that just came in this evening, then that would work.
Okay. Okay, sorry, I'm gonna stop for a second. They're vacuuming. I have to close a door, so I'll be back.
Tim,
Yeah, to the question of barriers, three come to mind quickly. You've probably heard these already anyway. The one is just too few, the number's not big enough. Not enough payers or attributed lives. Second one is the admin burden, whatever that looks like. And the third is opposition from non-primary care providers.
Eileen,
And that's basically what I had too. I think we've all worked together a little bit. It was what insurances, I use the term insurance payer, funders. That's an issue depending on whether everybody's in the pool or not. And there's a later question about Medicare that I think relates to that. Whether that is what percentage of that and how that would affect that. And then the other thing I think about with barriers is also what is happening now and whether we can compare that. So even looking at the change from what we currently do to what this might do, how do we compare that over time so that we can see if there's a change or not?
okay. John,
Yeah, two things come to mind for me. One is, how is primary care defined, and how do you provide payments for things that are, a bit beyond primary care or people that have a broader scope of practice? And then the other one is defining attributable lives. That's always a little tricky, and oftentimes not enough people are attributed to a practice who actually come to your practice because of the way that formula works.
Amelia?
Yeah, I'm
Yeah.
when you go wait long enough, everyone says most of yours, but the accountability aspects, I think too, just across the board from I think the vagueness for me of like what does an interested stakeholder mean? Are we opening that up to people who do or don't need to be in this? And then echoing a little bit of Eileen and adding on of like how did you measure the burden when they had a pretty specific decrease goal? Like how are you measuring that? And like I'm very fascinated how they thought that would come about. So I think there's a fair amount of the barriers besides what everyone's already mentioned.
Okay. Okay.
Thinking about a couple of things here. From my conversations in the steering committee, I specifically asked one of the lead folks in Massachusetts about their legislation. I said, who hates this bill? And he gave me a fairly positive answer about that. He said, well, the hospitals, it's a challenge for the hospitals because they're losing some control in this, but he felt like there was good support in Massachusetts for it. They have built into their in terms of the admin burden, the House bills House and Senate bills both talk about not adding administrative burden and actually getting our quality measures down to a menu of 12, and we can choose 6 of them. So it's certainly at least in the front of their minds. I know that that doesn't mean it gets implemented perfectly, but it's good that that message has gone through. There was something else I was going to mention though. Oh, about the pool not being big enough, which I think is definitely an issue in Vermont. In the Massachusetts bill, they have something that includes all of the ERISA insured groups, which has made it a much bigger pool. I don't understand the technicality of how they did that, but they feel like it's that it's functional. So that's something to think about there. So it just really expands the pool of people whose insurance can pay into this pool. Admin burden opposition, 1 second, how primary care is defined, that is always complicated, although I think there are sort of operational definitions that have to do, we talked about this in steering committee. Someone's gonna have to help me with the acronym NSCSA. There's a New England something collaborative that has a primary care definition, and I think that's probably the one that is most commonly used.
NESCO, was that the
Yeah,
primary care investment? Okay.
NESCO. Yeah, exactly. Yeah, those are all, I mean, I think all of those things that you all mentioned are true. I think that there's been at least some attempt to address it there's at least awareness of it in the House and Senate bills, I think.
So some of these things that you've mentioned, I'm wondering if you have ideas for mitigating. So like too few lives, it sounds like in Massachusetts, they have something that brings in ERISA plans. Are there, we mentioned attribution. Are there ways of, constructing attribution? Like there's not one method for attribution. So are there, is there a way that you would propose? Like, are there solutions to some of these issues that you've raised? Okay.
I think I don't personally know what the issues with attribution have been before. I don't know what's gone wrong with it. But I think the goal has to be for every Vermonter to have a primary care provider that they've seen in the last couple of years. And to me, that may be overly simplistic, but I think that's how you attribute that.
My I don't have a detailed knowledge of it, but obviously from a billing standpoint, it's considered your patient if you've seen them any time in the last 3 years. That seems like a reasonable definition, assuming they're not, seeing someone else also. I guess I'm not sure what to do if there's, more than one involved, how to do that. But my understanding of what's happened in the past is that the people who are attributing it will say, well, they're not your patient unless you've seen them once or twice in the past year, which, then that takes a huge pool of people that maybe don't need to be seen, but are, your patients and still messaging you and that kind of thing.
Great. Lee?
Got it. All right. I guess, again, I don't know what all the attribution problems have been. And it doesn't seem that this should be all that difficult. I mean, if it's coming from the patient end, who is your primary care? And then if they don't answer that, then we have to figure out a way to get them one. But it should be up to the patients to some extent. It shouldn't be coming from any central organization, because that's just going to mess everything up. How often do you need to change it? How does it get changed? I don't know the answer to that because I don't know what the problems are. But this doesn't seem like it should be very difficult. I mean, I was in HMOs a long time ago and they didn't have any problem with that. And I'm now in my direct primary care practice. And I don't have any problem with that. They tell me whether they're coming and paying me or not. And so we should try to keep it simple, stupid, and not get too many people involved in this attribution thing. And if it's the patient and some central authority and the doctor, we're good.
Great. Tim?
My not well-informed understanding of attribution is it has to be an individual, which creates problems when patients kind of don't really have chronic problems and they see a bunch of people in the practice, and then who's it going to be? And so it would be helpful if patients could be attributed to a practice and not necessarily an individual.
Board Member Merman?
Is that all right if I weigh in on some thoughts here?
Yeah.
We talked about having everybody a primary care provider in Vermont. I think we have a different workforce than we had pre-COVID, at least in my region of Vermont. I certainly feel like there's a lot of people leaving primary care, or at least a rapid turnover. So I do have concerns about how are we going to get everybody a primary care provider in Vermont over the next couple of years without being stuck with the other concern that I have is a whole bunch of 15-minute visits where you can't really establish a relationship as a patient with the provider or the provider with the patient. And so I guess my question is, I'm a little bit worried when I read through these bills of the workforce issues. I'm a little bit I would argue that I think these bills are a big step into moving towards stabilizing the workforce and some improvements there. So, but I do think that there may be to be some realistic time horizon expectations on that. And then how these bills allow the sort of flexibility that a capitated model brings to have more flexibility with scheduling patients for different length visits, for asynchronous communication, and continue to get attributed credit for that. So, and I must admit, I didn't read the House bill as closely as I've read the Senate bill. So I just want to sort of rethink about that. Does this go far enough in providing that enough payment at base to allow for more flexibility in the delivery of care? And then the other concern I have is how do we ensure that hospital-based primary care, this money just doesn't go to the revenue side of the hospital budget and everything stays the same. And so how do we ensure that that this leads to the delivery of primary care that is intended in the bill?
John, you're next.
Yeah, just on the attribution thing, one of the situations that we have run into is where there's a situation where it's required that the patient make some type of a choice, and that is challenging if the patient isn't organized enough to do that, or able to make an election, even though they may be a regular patient of yours. So I think there needs to be something that can be done administratively or based on some other process than just the patient electing it. Obviously, if the patient is paying you, Lee, they're they're your patient. But there's situations where that's not the case, and this bill is such that there is no copay, so it makes it even less incentive for the patient to sort of be attributed to the right practice. I do agree with Tim's practice application, so that it then the practice can figure out how to divvy it up from there.
Eileen?
One of the questions I have actually relates to who's in there, which is there was a comment in the bills, and the bills are pretty similar about self-funded, self-insured companies, self-insured employers. and whether those are necessarily included. But that gets to these devil is in the details that everybody's talking about. So when I think about it operationally, there's a lot of comments being made. They're really helpful, but who's making those decisions? So when it gets to operationalizing it, are the definitions one that actually work clinically? And is there somebody clinically involved in doing that, in sort of designing that? But then you have to work with what you've got already. And there's no way anybody can or should totally redesign the data and the measurements. So just thinking about that transition from what we have to where we're going and who's actually pulling that, getting the data designed so you can pull that, measure it, pull it, define it.
Okay. Amelia.
I agree. I definitely like the practice aspect. I think just even going further back, if we're saying who's primary care, there are a lot of people who've been told, OB counts as your primary care. Are they going to be doing the PAC visits or the acute visits? So is there a double coverage? So I think kind of echoing maybe I think what the Presti said, kind of making it simple is starting with what are we considering your primary care? And then expanding that into, okay, who that fits into. And then it sounds a little odd, but I think education for the actual patients as a whole, because all of us have been doing this in different varying of years. And what we think means, hey, this makes sense. A lot of patients don't understand. You haven't seen us in 4 years. You're not our patient anymore. That is kind of they don't think that just because they don't need an issue, why wouldn't I come back and just show up after 5 years to come look at my toe? So I feel like there's a little bit of that aspect to include the patients in this as well, in the sense of how we're selling this, in the sense of we want you to have a person and here's why and what this means.
Yep. So it sounds like we might need a multiple pronged approach, keeping it as simple as possible, like Lee mentioned, but there may be multiple ways to attribute Faye.
I think the data on why primary care has such a big impact is the strongest when the patient has a personal relationship with the provider. And so I have no problem telling my patients they have to show up once a year. They don't have to have a physical, but I have to see their face once a year to stay to I know the insurance standard is every 3 years, and I know there are reasons why 22-year-old guys might not need to be in, but I want to know them. And to me, this per member per month thing or this capitated payment actually sort of encourages that, like just once a year, let's have a face-to-face, make sure we know each other. I think that's where you get the most impact. I think that Dave is right. It is completely right that we don't have enough primary care providers to do this kind of thing right now. But I think I have a little bit of a field of dreams approach to this. Like, we got to change something. We absolutely can't keep doing what we're doing. And I think if we had a system where we could pay primary care providers a little bit better and decrease some of their administrative burden and have specialists in primary care work better together, I think we could, if we built it, they will come.
Thank you, Faye. Lee?
My usual contribution to this is let's let Faye decide all this stuff because she's got it. She doesn't like that idea ever, but she is the chairman of this primary care committee. She's got herself into it now, and I think we just vote for her.
Great. Well, maybe Faye will have more to say in our next question. So I'm gonna kind of circle back to some other issues. So, there's in a capitated model, there's documented risks of stinting care or cherry picking patients or et cetera, things we don't really love to, we may not think we're doing, but could exist elsewhere. Do you have thoughts on how we might kind of either write into this bill or other mechanisms of, making sure we avoid these kinds of issues? Okay.
when I think about this, I think about that any capitated payment is going to have to be risk stratified by age, complexity, maybe socioeconomics. I mean, there's a lot of different factors that could be put in there as multipliers. And I think that if those were built, those multipliers for complexity were built correctly, there would be less chance to cherry pick. So that's something I think really needs focus. In that Massachusetts bill, which I will send a summary out to y'all, I can send you the hundreds of page 1 too, but I haven't read that. They have a sense of how they do the multipliers, and it's I'm sure there's pitfalls, but it looks good when you read it.
Okay, great. Eileen?
Just to build on what Faye was saying, my thought was to connect with what I said before, it's how do you have a clinician in there? And we've not really had that necessarily before, that direct involvement. I don't know that the Primary Care Steering Committee, of which Faye is chairing, is doing that necessarily, but that is a place to get practicing clinicians to review either the bills or the potential for the design, the structure, the data as to moving that forward. We've not had that before. That's actually a good source besides us.
Great. Thank you. Tim?
I am unabashedly showing my FQHC background, but you could have, in order to participate, you accept all patients.
One way to do it. John?
Yeah, I like that. The other, and I agree with Faye, it's going to have to be pretty complex. I've also wondered if there's a way to kind of measure it in real time, because you can have a patient that one day, hasn't seen you in a year, the next day needs to see you, 3 or 4 times in the next month. And if there's a way that it could adjust, I mean, all of that data is in our records, and all of the touch points, not just the face-to-face visits, the coordination, specialty interactions, all that kind of stuff. If there's a way that it could be measured, that would be fantastic. That might be pie in the sky, but that would be my dream.
Lee?
As somebody who actually, does this and gets paid capitation by patients, folks, it all averages out. There are people who don't see me for 6 months and still pay me, as you would be being paid here. And there are people who see me 3 times in a month, and then they may not again see me for another 3 months. And a lot of people don't see me because they take advantage of texting and emails and things like that and get their questions answered without coming in. And so lots of those things, it's hard to do that kind of stuff, but you got to go a little bit with the averages, and understand that it is all going to average out. There are going to be people who use a lot of services, and there's going to be a lot of people who use not very many. And that's okay. That's the way it works. You're not going to have a fair amount, and say, oh, well, this person saw me 3 times this month, so their rate needs to go up next week. That gets into way too much complexity. We got to try to, as much as possible, keep it simple. And I adjust on the basis of age, and that's it. And it works pretty well. I mean, as we all get older, we get sicker. We need more care. As Faye said, the 22-year-old guys, man, boy, getting them in is a chore. But they're still paying me. So I'm frankly okay with that.
Thank you. So if the stated, I'm going to switch to another question and keep us moving along so we can get to the rest of the the areas. But, if the stated goal is to increase access, what are some ways that we can ensure this program, however it is designed? I think you guys have all raised a lot of different ways of implementing it, but that it's really kind of achieving its true aim. So how would we know that it's working?
We talked a little bit at steering committee about a couple of ideas for this. And one thing, let me go back to the question about stinting on care, Elena. One of the things that we've talked about in steering is that leaving some ability, some level of fee for service in addition to capitation might make sense. And one example for that one person brought up was if you got fee for service for doing same day acutes that kept people out of emergency rooms, that would be a way to incentivize that. I think, and that's increasing access. I think that, I think you could build into the system an incremental increase in payment if you had expanded hours, if you had weekend hours, if you some of that is written into the Massachusetts bill. So incentivizing extra hours or leaving being able to see people for acute care, which should happen with a capitation system, I think would be beneficial. There was something else that, more so than just age, I think would have to be baked into the capitated payments because of the wild differences in health in the different socioeconomic areas. So if you do zip code or if you do something with socioeconomics, I think that's important in there.
Great. Eileen?
I think if I remember, part of your question was also, how do you measure that? How would you know if there's a difference? And I come back to previous conversations we've had in this group about emergency department use, urgent care use, multiple of those admissions, readmissions. One would think that would all show up. The other thing I think of that's a little harder though is tests and multiple tests, more expensive ones, echoes, CTs, MRIs. That people are needing more of those is sometimes an indication of more complexity. So again, it's getting at the complexity, but I think some of that would be capturable as well.
Thank you. John?
Yeah, I think if it works, we'll be able to recruit primary care docs to Vermont. They won't want to go anywhere else.
Good outcome. Armin?
Yeah, I was going to say the same thing. Workforce stabilization, I think, is I think an indicator of it doing well. I think a lot of the kind of long-term population health indicators are going to be pretty lagging. I think it's going to take a while for people to develop trust and relationships with providers where they, and I think people have become so used to going to urgent cares and express cares and ERs for cares. I think it's going to take some time to change that view and to be able to have that conversation, that no, you can get that x-ray tomorrow or come see me, or I can steer you to a lower cost site. So yeah.
Great. Tim?
I mean, there's really a crude measure, but just the number of primary care providers in the state, the medical board keeps track of who's retiring, who's coming, and also perhaps some metric surveying practices about how many open provider positions do you have that are unfilled still.
Great. Michelle?
Just to, excuse me, tag on to what Tim said, that remember that's not all inclusive. The medical board doesn't track anything to do with APRNs and our private practices. So, I mean, that might be something where Mary Kate and By State can help us if we're trying to track in that respect.
Yeah, just making sure we have the full population of providers.
And just to comment on that thing is, I think we need to think about the FTE not the number of people, because I think I don't know, I'm looking at you. I don't know how many people work full-time in your world. I mean, in the ER, there's now 3 people in my group that are full-time. Nobody can tolerate full-time. And I think that's a pretty common way to sort of like mitigate, working late in the evening.
My hand up was, I think I'm one of the few in ours right now that's still like a 1 FTE. So
Yeah. I have not been 1 FTE ever in my 30 years. I've always been 0.75, and I would have jumped ship a long time ago, I think.
Helpful. Okay, I'm going to move to the next question. So given that there's not a lot of extra money in our system, how might we think about funding this increased investment in primary care? Yeah.
I mean, if it's truly a zero-sum game, which it can't be because of aging population and more chronic conditions, I mean, in order for somebody to get more, somebody else has got to get less. And I'm trying to say it shouldn't be patients necessarily that get less. And so then it comes down to, okay, it's either the clinicians and or admin that are going to get less. This is a war that I've, for 35, 40 years, wondered when is it going to happen between primary care and other specialties? And it's a national war. And so I don't know how the heck little Vermont is going to take this on. So I'm not very hopeful about that.
Lee, thank you, Tim.
When I read what I read of the bills, I didn't actually read the whole things yet and compare them and do a nice look at them like that. But if they're going to cut our administrative stuff to 10% and we're not doing billing, because we're getting paid monthly, there's going to be money available because, I'll refer back, it was a long time ago, but I did a deal with the Vermont Country Store and took care of their patients. And they saw all kinds of savings because they were paying us capitation because they didn't have to pay somebody to process all the bills. And that money would be freed up. If somebody's paying us capitation once a month and they're not processing 400 bills from each of us every month, that's a tremendous amount of savings. And that's where a lot of the money is going to come from, that will make this more doable. It still has potential issues, but, if we're going to, give up the opportunity to do all that fine billing, and get paid more for it, to John's point, everybody is going to be coming to Vermont.
All right, Faye.
Yeah, I mean, I was going to say a little bit what Lee did, that ideally, if we were getting a member per month for all of our primary care patients, that would at least decrease some of the admin, the many people involved in billing in our practice. And to Tim's question about where's the money coming from, I think if we have a system that really works the way we on this committee have envisioned for years, which is that we see our patients we keep a broad scope of practice. We see our patients when they need to be seen. We avoid people going to urgent cares and emergency rooms, avoid unnecessary hospitalizations. There will be less, money will be saved because there'll be less people in specialty care. And another part of what we've talked about a lot in steering committee is more functional relationships between specialty care and primary care, so that our specialists aren't doing the routine follow-ups on stable problems, which is what happens now, when they could easily go back to their primary care provider. So to me, the savings is really clear where it comes from. I think the harder way of saying that same thing, the harder way of saying that same sentence, is that there will probably be less business at the tertiary care center. And is that okay? How's that affect them? Are they going to be unhappy about that? Can they keep afloat? I think ideally, there's less business being done at tertiary care if we have a primary care based system that's functioning well. And I think we have to talk about that somehow.
Great. Dave?
I just wanted to say something about Lee's comment, which the first time I heard about like a fixed perspective payment was with the all payer model, and I was at CVMC and we were talking about some finance committee, and it just, the physician response to capitated payments and global budgets is you're like, yes, I don't have to do all this billing. But from the health policy side, everybody relies on claims data. So if you're thinking about risk adjustment, all the quality measures, all of that stuff, still relies, at least we haven't come up with a better solution than through claims data and billing. And just one other comment that I was thinking about while reading through these bills is, to kind of piggyback on something Faye just said, is that you could see a world where we need more primary care providers. We need primary care to be elevated to sort of a greater status in the House of Medicine. And, this to me seems like a major step forward in that direction. And what you might not need so many of is what we've been training a lot of lately as specialists, because if the primary care providers can develop the relationships with the patients and they can have the trust, and they manage the chronic diseases and not have your COPD managed by pulmonology and your AFib managed by cardiology and your Crohn's managed by gastroenterology, then the specialists are a lot more freed up to see the consultative patients. And where I work, a lot of patients really see specialists for primary care. They see cardiology for so much of their care, and then maybe the primary care provider for their gout, but most of it's run through the specialty practices, and for some patients in some practices. And so I could see a world where you actually have a lot better specialty access as you redouble down on the primary care model. But anyways, again, a little bit of a dream.
Thank you. All right, John, and then Tim.
Yeah, I think somehow you have to change the incentives for the proceduralists, because as long as the hospitals and proceduralists are being driven by their bottom line is totally dependent on volume, it's really going to be hard for primary care to affect that, because it just runs the whole system. So almost the similar thing needs to be done for other types of care. I just recall I was involved in a HMO a couple of decades ago, out not in Vermont, in Virginia, where they capitated they know that we know from the literature that for example, doing orthoscopies on people that have DJD is basically not of much, if any, value. And so they just said, look, we're going to capitate the orthopedists on orthoscopies. And in 1 year, the number went to like 30% of what it was the prior year. So there has to be other ways to address that gravy train that just keeps procedures going that aren't necessary.
Hey, Tim?
Apologies for digressing a little, but I'm sort of stemming off of Dave's comment about claims stuff. If with claim-based data, you're driving tons of stuff, risk scoring and everything else. At least the organization I work for is kind of late to the game and being really good about zhuzhing the chart and putting in everything for claims, so it's got a number next to it. So I think we could get primary care providers flocking to Vermont if the transformation funds were used to purchase AI that equalizes the charts, because there's all kinds of information that's unstructured in a narrative note that explains all the stuff that the provider's done and all the complexities of the patient. But at least in my organization, the providers were kind of lax and would just put maybe the first 3 things they talked about on the claim, where in reality, they covered tons of stuff. So if you can get AI to consume the chart and make it fair across all, because some providers are really good about putting everything into a claim, and a lot of them, at least in my organization, are not. And so that would be my dream, is to see AI applied to equalize claims-based data.
Great, thank you. Faye.
I was going back to David's comment too about ideally moving some primary care out of tertiary care. And I think that's one of the things that if you were looking at what we wanted to incentivize, there should be a way within the per member per month, within how we tweak that, practices that practice a broad scope. I think we really want to incentivize broad scope. And there was one other thing. Oh, other thoughts about tuning up the relationship between specialists and primary care. You know, one of the things that would make an enormous difference in my life is being able to talk to specialists on the phone. And I wouldn't abuse it, and I wouldn't do it that often, but every now and then you've got someone in the office with some acute rheumatologic problem, and the next rheumatology appointment is 4 months away. And if you could just talk to the specialist while the patient was in the office, you could talk about the esoteric labs and what med to start on and all of this. So we would do so much better referrals if we could have a phone call with a specialist beforehand. They're not incentivized to talk to us on the phone. We are not incentivized to talk to them on the phone. So some way for us to actually talk to each other. And I don't want to hear about e-consults. I don't want to upload information and get information back from a specialist a week later. I want, in the moment when I'm seeing the patient, to have a conversation with a specialist. And that would have to be financially incentivized for the specialists as well. You know, you can't ask them to talk on the phone to us all day. But it would make a huge difference in referral patterns. And the other thing with specialty that we've talked about is, you know, could you somehow make it part of their responsibility to tick a box at the end of their visit that says this patient is stable to return to primary care management, or this patient has complexity that requires specialty follow-up. Just make the specialist make that decision so that you know, we end up getting the patient back with a clear plan and not necessarily them seeing the specialist every 3 months for something that we can manage in the office.
Great. Thank you. Okay, so with the rest of our time, I'd love to pivot to kind of some of the more GMCB focused activities. This was all very helpful and I think good comments. So these bills give commercial rate setting authority in primary care to AHS and our partners at DVA or Medicaid. How should this work integrate with GMCB's broader provider rate setting authority? Okay.
I have no idea how to answer that, so I hope you don't think my raising my hand was that I had an answer. I guess I would want to ask you, what are the inherent or intrinsic conflicts in that, in the fact that GMCB has rate setting authority and AHS and DVA does too? Like what would we anticipate?
So, I mean, I think right now we have provider rate setting authority. As you know, we're working on reference-based pricing. So that could mean setting references for, you know, hospital-based care, and it may or may not align with a definition of primary care. You know, we have the option to establish floors. We have broad rate setting authority, so it could be beyond reference-based pricing. So I think, you know, I think the question is really, we have these authorities. Would we then carve out primary care as something separate that would be administered and regulated by AHS? Would we, you know, we also have rate review, which means, you know, we have an ability to think about what insurers pay for primary care or other areas. So I think there's a lot of intersections that could come into play. And so just wondering kind of from an, administrative, and this may be a reach ask. So if there aren't great thoughts, that's okay too. But Eileen.
I think they should be integrated and aligned. What that means is a different story. The comment about the description you were using about, how much do you bring in primary care or how much do you carve out? One of the things I've said for many years now is we don't have a healthcare system. There is no system. There is no integration. And I think this is one piece of it that it does need to be. Does that mean everything falls under Green Mountain Care Board? No. But there needs to be some integration so you don't have this carve out or that carve out. And inpatient versus outpatient is another thing that's come up over time, that those are not disconnected. Those are not discrete silos. And so there has to be some alignment somehow. Again, we'll get into the weeds and the details, but that's not what we do. Because then we're telling somebody who actually knows how to track that and integrate that and make reports, generate reports and such, doing that. But I don't think we can do anything other than integrate in some way.
Great. Lee.
I thought meeting long ago that we talked about people figuring out what the Green Mountain Care Board could do with regard to primary care. It sounds like some of it's been figured out, but I didn't get the memo. So I can't answer this question because I don't know, what the roles of AHS and DVHA and the Green Mountain Care Board would be with regard to primary care. And I guess I'm also a little puzzled about commercial rate setting because if we're talking about capitating people, then there's a capitated rate that should be paid by everybody. And who's going to set that rate? That's a whole different question. Who should set that rate? I don't know. And I will also put in one more plea because I've been getting a little bit nauseated with all the incentivizing of this and that, because that's not keeping it simple, stupid. The more we do this, the more we get back to the billing system that we're trying to run away from, where everything is incentivized.
Great. Tim.
Yes, I'm probably just expanding on what Eileen and Lee said. I mean, I don't have an answer. It would be wonderful if it was uniform. And again, from the FQHC perspective, I'm hearing more administrative burden with, there are rates that are paid by Medicare that are set by Medicare, and then different sets for Medicaid, sort of encounter rates. And now a third body getting involved just sounds like the CFO is probably going to shoot her head.
Okay. Dave.
Can I just, excuse me, Elena, if I'm totally, I just think, can I just say what I think that at least the Senate bill does so that we're on the same page about, so my understanding of the Senate bill is that they would take commercial money and then Medicare money and Medicaid money where they can, create a fund, and then they would do they being DVHA, I believe in the Senate bill, then would do the whole kind of capitated payment distribution of the fund, setting the attribution model, the risk adjustment model, the payment amounts, the quality metrics. And I think that's right? And then that is in consultation with the GMCB, and Faye, your committee, I think, is listed in there as well. Is that's the basic structure, right, Elena? Am I getting that?
That's my understanding, yes.
Okay.
So payers could pay in differently, but the money that comes out for each patient to each provider, depending on how you attribute, would be the same, and it would all be administered and overseen by AHS.
So in some ways, I think that keeps with Lee's kind of KISS approach, where you have one entity distributing the money. The complexity of it, and as I read through the bill, is we don't necessarily have Medicare buy-in to doing this, right? So then, as Tim was mentioning, you could have Medicare fee schedules that you'd have Medicare potentially in a fee-for-service model, and then you could pull Medicaid and commercial. But I guess the intent is to pay out evenly regardless of the patients that you're seeing. Is that how you read it?
Yeah, so actually our last question with this, so we can just jump right in because I think it's relevant. But so I think you're right. These bills presume Medicare's participation, but we don't know that they would be willing to do that, or that it would be aligned, or that we would be able to even design it, right? Like I think a lot of what we're hearing from Medicare is here's your option off the shelf. Take it or leave it. And I think there's still negotiations that may happen, but it's not, I think, what we've been describing. So if that's the case, if Medicare looked different or was not at all what we're talking about, would this still make sense with a subset of payers being Medicaid and commercial? Wait.
I'll go out there and say that it would be, because it's still simplifying some of the system for some of our patients and making it easier to do what we do and not have to worry about some of the stuff that we are currently worrying about. And I can't see a world where Medicare would be cooperative, frankly, but because they know more than anybody about anything, from what I can tell. And I just think that anything that makes it simpler and pays fairly, of course, is a plus.
Any other thoughts, or we can move to the next question?
I agree with that.
Okay. Do you have, another part of the bill and another role we have at the board in these bills is to do some updates and reporting. We have, I can pull out that section if that helps. Let's see. Of course, it's not right in front of me. I think some of it was about kind of labor market and other things, but I'll pull that up. But do you have thoughts on reporting that would be helpful either to influence setting up this program or kind of monitoring over time? And I will pull up the language. Eileen.
Much as it seems patently obvious, one would hope that the reports crosswalk with what the goals are and the objectives are. So, I mean, you have to say it just because you never know if that's actually going to be what comes out of it. So that you can measure if there's less expense, measure if there's less ED use, more primary care use, less specialty use. If the administrative cost goes down, then that can go somewhere else. And how do you track that? And again, I come back to, don't rewrite the whole thing. We got to work with what we've got and then transition somehow what data we have and can we measure a difference. But we should be able to crosswalk that at some level.
Any other thoughts on reporting? Okay, and of course now I found it. So it's an updated version of the board's 2017 Vermont Clinician Landscape Study, and an updated version of the board's previous reporting regarding site neutral reimbursements, including the current state of reimbursement differentials based on practice setting ownership type, along with any significant efforts that have been implemented since 2017 towards site neutrality. So, you know, understanding where folks are coming from now, moving towards a payment that would be, you know, the same for everyone. You know, how might we think about site neutrality? And are there any other ways that we should be kind of considering? Any other things we should take into mind and as we develop these reports?
I might be getting a little lost in the terminology, Elena, but the reports meaning data that the practices send to Green Mountain Care Board, data that the Green Mountain Care Board extracts from usage. I'm
Yep.
a little bit lost
So-
about.
Sure, yes. So I think, so let's take the site neutral reimbursement report. So the Green Mountain Care Board has over time updated reports on provider reimbursements and how they differ across settings. There are a lot of ways that we can do that. So are there, you know, presumably this would help understand where folks are currently in their reimbursement as a rate is being established. So are there certain factors we should be thinking about in producing the next iteration of this report for this purpose? Again, this doesn't say how it would be used, so it's kind of hard. But are there, like, how would we want to use this, or how would other folks want to use it? I guess I'm presuming it would be helpful in establishing this program, as would the landscape study on, you know, practicing clinicians in Vermont. Lee.
I guess I thought the point of this was to make the payments site neutral. So I'm not sure why you need a report about that. But the other thing I would say is that, you know, one of the things that has always bugged me about, say, Medicare and other places that, you know, want reports from us is they get down into little fine detail about what we're doing in our office. And they don't look at the big picture, like, how many hospital days did your practice generate? How many specialty referrals did your practice generate? You know, that's big data that is out there, and doesn't have us having to dig through it, because that's one of the problems with a lot of the quality measures that I've seen so far, is that we have to dig through that data. And that's not really conducive to us doing our jobs if we're digging through data. So I would say that, you know, let's look at the big data that's already out there that we know about, and figure out a way to take the attributable people in my practice and say, how many times do they go to the hospital? How many times do they get a specialty referral? How many times do they get surgery? You know, for cardiac disease, you know, a bypass or a stenting, you know, that I could have prevented if I had been doing a much better job, that kind of thing. So that big data is out there, and we don't seem to use it very much. We use little data from the practices.
Okay, Dave.
So like a little bit on site neutrality. I think it's complicated to think about site neutrality in the context of a capitated payment, because then we have to think of, I mean, to Lee's point, sort of if this is the only payment going to primary care, if you're doing the full payment through a capitated payment, this isn't like a bonus add-on payment, like a one care payment, this is the full payment, then it probably needs to be risk adjusted to some way. But then we kind of get into Tim's issues with, you know, the practice's abilities to risk adjust, and, you know, a small independent practitioner is not going to have the EHR that's probably going to allow for optimal risk adjustment compared to, say, like a Epic, which is, you know, very sophisticated at that. So I do think when we think about site neutrality in the future, we sort of have to start thinking about it in like in a different way than a fee-for-service transaction if we're moving out of fee-for-service. But just to sort of reflect, and maybe this is actually for your prior question, but also kind of relates to what Lee just said, is, this isn't full capitation, right? The primary care provider is not going to be on the hook for the hospitalizations and the knee replacements and all those sorts of things. It's just for the primary care. It's not like back in the day when people were, looking at full capitated models. But it may be worth measuring that as a measurement, to look at how practices are performing, because as Lee mentioned, if you're successful, it's complicated because there's a lot of social risk involved with thinking about the total cost of like the per, we used in Medicare like PPPY or like the per capita cost per year. But it might give some insight as to sort of what's working and where and how people can learn from each other and optimize delivery. I don't know. So I guess that was sort of like, I think, a question to go discussing about measurements, but
Thank you.
so it's a thought.
All right, Eileen.
I'm thinking about how do you do the reporting and looking at the improvements in primary care or more primary care usage. And I'm going to use an example Amelia brought up because I've did family medicine for so long. There are patients who had care from a midwife, for example, and continue all of their primary care, well woman care, with a midwife or even with an OBGYN. How do you sort that out that is not a specialty referral if they don't go to their primary care for anything else because they happen to not need anything else? Or they may go to primary care for something, and that would not be the only example, but that's one of how do you sort that somebody getting that care is what you want them to get, but it's not in a primary care office, but it is their primary care.
And thank you for that, Eileen. I will send around this, and I should have sent it with the materials, but the landscape survey, I think there was an actual survey done at the Green Mountain Care Board of providers and focus groups to understand kind of some of these challenges that you've raised, but really on a broader level, kind of where folks are practicing, what the nature of their practices are. And this is one of the reports that would, is being identified to be updated. So, I think we're open to thinking about doing this differently. But I think that's another area, given we didn't send this in advance, it would be great to have your feedback if this part of the legislation continues. So we'll send that out. Okay. All right, so we're on the last question, but then want to leave time for folks to provide any other thoughts. And we'll kind of leave the synthesis. I think we can share back out some key themes we heard and, would love for you to review that and send us anything you think is missing if it comes to you later. But the last question we have for now is how should we think about how this work intersects with GMCB's existing regulatory duties? So I think, we kind of touched on this, but the Green Mountain Care Board oversees hospital budget review, rate review, and ACO regulation, so certification, et cetera. So do you have any thoughts on, how we might think about those duties differently if a bill like this were to be implemented? Eileen.
Just to repeat, integrate somehow and don't silo, because specialists and primary care and inpatient and anything else are not separate. It's still one patient.
Thank you. Tim.
Just assure that whatever the percent primary care spend is decided upon, that those institutions are held to it. If it's 15% primary care spend, then hold their feet to the fire.
Other thoughts on this, Dave?
Can you remind me who the body that would be responsible for holding 15%? Like, who's the entity who is responsible for that target in each of the bills? Do you know?
Would you mean for establishing the target?
No, for reaching the target. I mean, I think it defines 15%, but like, So, I mean, just Tim's point, so, you know, you can get to 15% a bunch of different ways, but if to do it just by increasing primary care spending without reducing spending other places is, you know, it's a lot of money. So, I would think implied in that is that you can more efficiently deliver healthcare and at least I think it says that we don't increase our spending, right? So then, in fact, I think that's in the Senate bill that it's not increased. So I think that
Yeah,
then you'd
that's a
have to somehow,
proportion.
you'd
Yeah.
have to somehow redistribute. You'd lower spending elsewhere, and I assume that's sort of implying then to raise it in primary care, not to lower spending elsewhere, so that primary care equals 15%. That'd be a lot of reduction. But who's does it call out who's the responsible for achieving that target?
So it says, shall increase 15% the department. So
DVA.
I think that's DVA shall establish a transitional schedule that increases the proportion of primary care spending over time in order to achieve the primary care spending target. That's the Senate bill. Yeah, so it's Medicaid.
Okay.
And then
So
in the
that-
House bill, it says the agency, which is the Agency of Human Services. So that may or may not be DVA.
Okay. So it doesn't identify, it identifies that they are responsible for increasing spending to reach the 15%.
Yes.
Okay. So it doesn't sort of pull out Tim's concern of is their spending going to be coming out of other places to reach that?
It doesn't say how. It just says they
Okay.
shall. It's yeah.
All right. Thanks.
Eileen.
I think the follow-on question to what both of you have been talking about is there's identifying the spend, but what is that spend? As you both were talking about is what counts as a primary care spend, and there needs to be some flexibility in there, but not so much that somebody can go totally one way or the other, that it's really not primary care. And then who enforces it? So if somebody isn't doing that, who's the actual enforcer who has teeth or who has the flame to hold feet to the fire?
Thank you.
I think I think both bills use the NESCO definition for what is primary care, if I remember. And this, I think Mary Kate's she was on this earlier. Thank you by state for this crosswalk. But I think they both use the NESCO definition to define what is or is not primary care. At least the Senate bill did. For some reason, I'm not seeing it right now. So at least that, I think, takes care of the first part of your concern. The second part, maybe the legislature.
So we have 10 minutes left of our scheduled time, but wanted to leave it open in case there are other ideas or feedback or thoughts you have for us related to our portion of this work. Tim.
I don't know if you probably don't have any input. The Green Mountain Care Board doesn't have any impact, but the House bill got into specifics about dollar amounts to support workforce type things. $1.25 million for the Maple Mountain residency program. One thing that I wish was there and is not is support for a APP residency program similar to, based in local practices or F2HCs in Vermont.
Okay.
I just wanted to say two things. One is whenever we are talking about quality or how many people in our practice are admitted to hospitals or ERs and all of that, I think that there's got to be a total shift in quality measures where we look at and scrutinize the outliers, not make all this data shoveling happen for everybody who's in the middle of the bell curve. So what I mean is, instead of making us all do prior auths for every whatever, look at the people who are overusing the system, look at those folks and see what education or what practice changes are needed. It's just that's just a principle that we keep coming back to in steering committee that I wanted to say here. And finally, I just want to say thanks to everyone for getting together for this tonight. I know PCAG's been a little bit more ad hoc recently. I'm only on the steering committee because I represent PCAG, so it felt really important to me to get us together again and share our thoughts. And it's really helpful for me to be able to say what we've talked about here when I go back to steering. And I want to continue to be able to do that. So if you all want to send me little emails with any fun stuff in it, I'm welcome. I would really welcome it.
Great. Any other closing thoughts? Okay. Oh, Michelle.
I would just say, Faye, and for everybody in the Senate bill, when I was reading it, there is talk about the reducing of administrative burden. And it was quantified with what I thought was maybe unrealistic reduction, but I would just say that I think that we really have to look at that. And for those of you who don't know, I sat in front of House Health a couple weeks ago or 10 days ago because they wanted to undo the prior auth stuff that we just got done. And I said to them in very polite terms, knock it off. And I do believe that's not something we're going to have to worry about this year. But basically, I just said, why don't you at least wait for the report so that we can see what issues there are or are not before you try to undo something that we as PCAG have worked how many different times, how many different years over the last, 15 years, Faye, that we've been going down that road. But the administrative burden is really an issue. And I'm back playing in primary care again a little bit, which I hadn't been for a while, and really fully understanding what my colleagues have been telling me about the burden, especially in the FQHC world. So there are a lot of people that are not able to work to the fullest potential of their license because they're burdened with paperwork.
Dave?
I think it's so important. If these programs pass and they're going to be run by, under AHS, either AHS or DVA, but it's all under AHS, that there is some opportunity for providers like yourselves to help guide the reduction in administrative burden. Just saying reducing administrative burden. I think that I'm not a primary care provider. I speak with primary care colleagues. I hear things, but it's very different to live it. And I think to explain the lived experience of what the impact is to then try to figure out the solutions, I think is going to be really important. So I don't know if that could be added to the bill so that there's, but it's guided by Faye's committee. But I think that these things are going to be really important because, my administrative burden, the ED, is very different than administrative burden in the primary care world. And I think the administrative burden for people at DVA and AHS is very, they don't live it. So anyways, keep fighting the fight.
Great. Okay, well, if you have other ideas that come up, you know where to find Faye, or we're happy to take them and incorporate them. But thank you for your time and all that you do. So take care.
Thanks, everybody.